Welcome everyone to today's program. I'm Shanna Barnett with Becker's Healthcare. The program will begin with a presentation and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the talk and will follow up on any questions they do not have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation, however. It is now my pleasure to introduce one of our presenters today. Dr. Kristen Boehm leads Nxera's value analysis programs at multiple client hospitals and health system sites. Using Nxera's physician-led approach, Dr. Boehm facilitates physician engagement as well as the integration of the value-driven decision-making framework required of providers in new models of healthcare delivery system. Dr. Boehm's perspective as a practicing surgeon, coupled with her strategic purchasing proficiency, has enabled her to play a key role in launching successful value analysis programs at several regional hospitals, most notably client organizations interested in change management strategies encompassing both cultural and operational. It is now my pleasure to turn the floor over to Dr. Boehm to begin today's presentation.
Thank you, Shannon, for that introduction, and thank you, everybody, for joining this afternoon. Today's presentation is going to highlight the rationale for recruiting doctors to be part of the value-driving team in our hospitals. We're going to start by pointing out what's changed in healthcare that makes this so crucial, and then lay out some of the tactics to bridge this from the theoretical to reality. We'll talk about some of the ideal characteristics in physician champions, which will then lead us into the actual framework and structure that's necessary for the right people and the right processes to yield effective, tangible results. So to start out, it's undeniable that the business and practice of medicine is changing. Hard work and good intentions no longer guarantee sustainability for our hospitals and physician practices. Of the approximate $3 trillion annual spend on healthcare, overuse of services accounts for hundreds of millions of that. And some would argue that despite these astronomical numbers, we're not getting our money's worth when you consider some statistics that are reported from an issue of the Saturday Evening Post, which, for example, rates U.S. life expectancy 45th and puts us near last in terms of infant mortality behind countries like Jordan and Bosnia. And lest you think that the implications don't affect you or your community, consider statistics like the fact that 87% of small and community hospitals anticipate declining profitability through 2015. And the average Medicare payment reduction is 0.61% per hospital stay. Looked at another way, 50 rural hospitals have closed since 2010, and another 283, or 13%, are vulnerable to shutdown. If in fact they do, that can mean the loss of 86,000 jobs in our rural communities and an estimated $10.6 billion loss to the GDP. So in response to these alarming statistics, Congress has replaced the growth rate reimbursement system with a value-based formula. So in layman's terms, the transformed reimbursement model is going to look less at the numbers hospitals do and more at how they do. In 2014, about 20% of all Medicare payments used a value-based model. The Department of Health and Human Services has announced a plan to have 30% Medicare payments in value-based arrangements by 2016 and 50% by 2018. The switch from a traditional fee-for-service model to a value-based one means that hospital reimbursements will be tied to outcomes rather than overutilization of healthcare services. Going forward, successful hospitals must adapt if they are to remain financially viable. A hospital that had a 2.2% net operating margin in 2011 would see its margin fall to minus 16.8% if it didn't change how it does business. Margins are predicted to decline this year, even for those hospitals that are deemed efficient. And this is not really a new phenomenon, as hospitals have suffered declining Medicare margins since 2002, averaging minus 5.4% in 2013, minus 6% in 2014, and minus 9% in 2015. A number of hospitals and other health providers will lose an estimated $11 billion in Medicare payments between 2014 and 2017 due to past overpayments. And disproportionate share hospitals are set to face payment cuts of $1.2 billion in 2016. So the upshot of all of this is that change is crucial to protect margins and improve the perception of healthcare in the United States. Prudent management of resources will now be rewarded over the number of procedures, with the overarching goal to slow the ever-escalating cost of medical care. Organizations that encourage their clinicians to be not just care providers, but true stewards of limited healthcare resources will be the most successful and sustainable going forward. The need to evaluate the cost, quality, and outcomes of supply choices demands a higher level of collaboration between all hospital divisions, including those departments that work directly with patients and those that in turn focus on more institutional or operational management. So the era of value-based payment means more than ever, finance leaders and physicians must work in tandem to meet top performance measures. Both are integral players in future strategies, and neither can afford to work in silos, ignoring the other. Creating this type of collaboration, however, is more challenging than it might seem on first inspection. Administrators tend to think large-scale, organization-wide, whereas physicians work as solo practitioners or in small teams. Administrators think in a more group setting, whereas physicians focus on individual patients. Administrators are known to often delegate responsibilities, whereas physicians rarely relinquish authority. And for administrators, they think about the future in terms of years and decades, while physicians think in terms of getting their patients through their next operation or an acute illness. There are, however, some common traits. Finance personnel and physicians are very precise in their work, and both rely on data absolutes and objectivity. They approach problems with logic and previously exercised judgment. And pulling out absolutely every stereotype, they both tend to migrate toward the type A end of the spectrum and possess, even if covertly, a competitive edge with a desire to succeed. So hopefully within this framework of similarities, there is some common ground that can be used to foster meaningful relationships between CFOs and CMOs. So from a purely practical standpoint, some may argue that it's completely unnecessary to find this sweet spot between those that make financial decisions and those that make clinical ones. After all, can't a hospital C-suite with their array of consultants avoid economic landmines and render decisions that keep their institution fiscally viable? The answer is highly unlikely. As it is, according to Healthcare Advisory Board interviews, 100% of PPI suppliers interviewed stated that they do not give their GPO customers the best price. Hospitals, on average, overpay 12% on PPI items. But interestingly, research indicates that physicians influence at least 80% of all product decisions, namely in the coveted and expensive PPI space. So by deduction then, active involvement of physicians in new product selection can potentially dramatically increase the likelihood of success. And so smart hospital executives are not asking if they should involve doctors, but how to more actively engage them. The system can no longer allow physicians rogue and indiscriminate buying authority, but these same physicians are integral to a successful buying strategy going forward. Physician engagement is key to the long-standing goal of improving outcomes and lowering costs. Healthcare facilities need physicians who can educate their peers about product or process improvements that optimize outcomes, but at the same time incorporate cost reduction. Such physician leaders who are vested in both clinical and financial metrics are the ones to ultimately lead quality improvement teams that establish evidence-based protocols and routine order sets that reduce variability and improve clinical outcomes. Reduced complication and readmission rates become one arm of hospital financial savings, both in terms of saved product costs and optimized performance as reported to organizations like the Centers for Medicaid and Medicare Services and the Joint Commission. And remember, hospitals will now be financially rewarded for their performance and by the same token penalized for failure to meet certain metrics. Additionally, with the new era of transparency, consumers are very sensitive to value as well, particularly as more employers are adopting high deductible health insurance plans that leave their clients to pay more out of pocket. So organizations such as those mentioned, like the Joint Commission, now provide patients with information on hospital measures such as hospital-acquired infections and mortality. The value of these ratings is underscored by a 2010 Thomson Reuters Pulse Healthcare survey, in which 60% of the individuals polled would rely on ratings over a community location in seeking their health care. Another 75% said that they would change hospitals if their facility received a bad rating. So the implications for market share and revenue generation become another consideration to the hospital financial bottom line and further impetus to optimize the value of care being delivered. Which brings us back to recruiting physicians as partners in the new healthcare paradigm. Fixing healthcare means moving to a team-based approach that has patients at the apex of the pyramid. In order to make what will be inevitable concessions on either side, it's helpful to understand where the other team is coming from. There are some ways that individuals from hospital finance can better see and understand the physician environment, and vice versa as well. This type of willingness and understanding can go a long way in building trust and camaraderie that can become the foundation for a very strong and lasting partnership within the hospital halls. So it's no secret that engaging physicians has historically been a challenge. Barriers include time constraints, lack of a defined common purpose, scarce leadership support, scant data, poor communication. Garnering physician support then means that hospitals have to develop creative and multidimensional strategies. And so what I'm going to follow with is a list of potential tactics that can be used in recruiting physicians to become part of the value team in the hospital setting. So for those that aren't normally in the clinical setting, go ahead and have a presence there. Stated otherwise, value the physician time with yours. This can take many forms, including meeting with physicians outside of an office and instead in a clinical area or in a physician's lounge. Stop by places like the ED, the cath lab, the ICU, attend rounds, attend a medical staff meeting. Maneuvers such as these can lend insight into the dynamics and decisions right at the point of care and enhance the understanding of what exactly it is that doctors do on a daily basis. It demonstrates a willingness of financial managers to get out of their own comfort zone in trying to build collegial ties with their clinical staff. The corollary, of course, is to invite interested physicians to financial meetings. Many physicians today are enrolled in executive MBA programs, either for purposes of managing their own practice, for running surgery centers that they have invested in, or perhaps even for more long-range goals, such as becoming a hospital CMO. Regardless of the rationale, these are physicians who have a demonstrated interest in the financial complexities of an institution. So deepen this understanding by inviting participation on finance committees, where details around things like billing and accounts receivable are discussed. This gives physicians real perspective on concepts like budget balancing and budget variance, and gives meaning to the potentially fatal consequences of unrestricted spending, borrowing money, and operating in a negative profit margin. But involve physicians prudently. Physicians like efficiency, and time is one of their most precious commodities. Not every initiative necessitates physician input. Some big-ticket savings programs in a hospital, things like food services, linen utilization, office supplies, they can be very impactful to the hospital financial bottom line, but less so to doctors. So recruit physician support only when necessary, so as not to dilute their enthusiasm for the process overall. But it's important to make this determination at the onset. Involving a physician midway through developing a clinical protocol or forcing them to adopt a new product that they use but had no input on leads to a lack of buy-in, no matter how acceptable that product may be. Initiatives that have potential clinical consequences are taken more seriously when scientific and financial evidence is provided by a physician champion with expertise in that particular field. Inviting relevant end users to lead the decision-making process augments the likelihood that it will be accepted and communicated throughout a department. Clearly define a cultural core value wherein executives and doctors are now partners in a system that's devoted to quality and safety. Executives must recognize that doctors are not customers, and doctors need to realize that they need to shoulder the responsibility for their institution's outcome, and not just their own personally. Shared purpose that emphasizes high-value care for patients will stimulate physician buy-in, since the physician instinct is always to put the patient care first. Create a culture that wants to meet patient needs and affirms that a group effort is needed to keep the hospital afloat so that it can be there in the future for these very patients. By the same token, when things go wrong and complications occur, as they inevitably will, scrutiny of the system processes, rather than ostracizing a particular individual, will reinforce the idea of a partnership with shared responsibilities, both in the good times and in the bad. Communicate candidly. When there is uncomfortable information, such as more stringent requirements around medical documentation, or perhaps previous bad blood from a failed joint venture, these types of things can be barriers to engagement. A lack of candid communication around them makes a physician less likely to work collaboratively on hospital improvement processes. Highly charged issues which have the potential to be divisive can actually bolster physician engagement when the facts around them are communicated proactively and promptly. Recognize the educational road to becoming a physician. Becoming a physician is a long process, beginning with prerequisites in college, trailing on into medical school, and completing any number of residencies and fellowships. Most physicians have subscribed to the notion of delayed gratification to some degree. Appreciation of that process conveys a level of professional respect that resonates with most doctors, and it makes them more likely to enter into relationships with their financial counterparts. Speak a common language. Most doctors derive professional satisfaction from achieving excellent clinical outcomes and doing so efficiently. Not to trivialize the financial aspect of what they do, but they gravitate toward biological systems over macroeconomics. So when it comes to a new product or a new process, physicians will be more interested in how it impacts their clinical outcomes or decreases their wasted time. A change that eliminates an unnecessary administrative task or optimizes patient flow will thereafter allow a doctor to spend more time with patients, improve patient care, and their professional satisfaction. So emphasize these metrics, not cost, when presenting alternative clinical items for approval. But by the same token, educate gently around the cost impact of clinical decisions. For all their education, physicians are often completely ignorant as to the cost of the procedures they do, the supplies they use, the drugs they prescribe, and the tests that they order. In contradistinction, sophisticated hospital accounting and charge systems mean that financial departments know the prices and reimbursements associated with every ICD-9 and CPT code. Share with physicians this data as it relates to supply costs and utilization patterns. For example, most orthopedic surgeons would probably be surprised to hear that, according to Orthopedic Network News, payments for a total joint replacement rose 27% between 1991 to 2008, whereas the average selling price for a hip implant during that same time period increased 132%. The average sales commission for an implant rep for a total knee arthroplasty was more than the Medicare payment received by the surgeon for that same procedure. This type of information resonates with surgeons personally, and thereby becomes a very powerful tool to influence behavior and potentially choose products with fairer pricing and curtail unnecessary utilization that isn't always linked to a better patient outcome. Additionally, use hard financial data to generate individual physician reports and comparisons to their peers. Comparative data showing variation in device usage can be a physician's first insight into how their choices affect margins. Include not only cost per case, but also things like readmission and mortality rates, length of stay, laboratory and pharmacy costs. Lower cost physicians who have the same or even better outcomes build a case for creating standard utilization strategies that lower overall costs. And providing hard copies of this type of data to an entire department feeds a bit into the competitive nature of doctors, who generally want to be viewed favorably by their peers. So I'm going to use an example from one of our own hospital clients. We found that data on the use of fibrin sealant indicated a total spend in this space of over $72,000. Analytics revealed that 90% of the usage was by a single cardiologist who was using the product on every single one of his pacemaker insertion cases. The chairman of our peri-op team took this data to the physician in question and pointed out the discrepancy in his usage with no clinical benefit over his colleagues. The physician agreed to change his practice pattern, which translated into a decreased usage and a calculated savings of over $45,000 on $72,000 of spend, which represents a 63% savings. In this particular case, a 3-month look back will be conducted to ensure compliance with the stated plan. But similar types of initiatives, such as this, like around bone cement usage, biologic mesh usage, medication usage, laboratory ordering patterns, etc., can potentially have similar yields in your hospitals. The question inevitably arises about financial incentives. Physicians typically care primarily about their reputation and patients' well-being, but naturally not to the exclusion of self-interest. There are tactics to reward collaboration and inspire teamwork as it relates to patient care. Annual look-backs at physician performance and linking these to contract renewal or maintenance of admitting privileges is one such tactic. Another relies on the notion of loss aversion, which states that people find it more painful to lose something they already have than they find it agreeable to gain it. So in other words, doctors are much more likely to alter their behavior when failure to do so threatens the loss of as little as 1% of their income. So both of these types of approaches can be effective, but at their core, they need to be linked to rewarding behavior that improves patient care, not focus solely on reducing costs. So failure to incorporate that aspect of the paradigm would only open the door for physicians to ignore the particular practice altogether. Non-financial rewards like positive feedback and respect from colleagues can also be powerful tools. Reporting physician performance, particularly in comparison to their colleagues, is a means of using peer pressure to achieve cost savings without compromising quality. Knowing that performance reviews can be made public can be very motivational. As an example, a particular institution unmasked their data on physicians' ordering of radiology tests. This almost immediately led to a 10 to 15% decrease in high-cost tests, mainly among the outlier physicians who tended to order more of these tests. No decline in patient care or outcomes was reported. Similarly, the hospital that I work at in Atlanta sends out quarterly emails containing an Excel spreadsheet noting the percentage of first case on-time start for the entire list of surgeons. So in addition to the acclaim, surgeons who achieved 100% on-time starts were given first preference when booking add-on cases. So needless to say, the number of physicians attaining what has been termed golden status has increased every quarter. So at this point, we've emphasized that physicians and hospitals must be aligned with the goal of better outcomes and greater cost efficiencies. We've enumerated ways to engage physicians in the value proposition and incorporate them into the financial fabric of the organization. Not all physicians, however, are ideally suited for the role as physician champion, and careful consideration should be given to who can best balance being a worthwhile clinician with simultaneously serving as a value strategist. The skills needed for this role are not necessarily ones taught in residency, nor ones that land an individual a department chairmanship or national podium time. It's often the atypical physician who makes an ideal champion. Many physicians are autonomous and make unilateral decisions on a daily basis. They like to be the one calling the shots. A good physician champion, however, operates more as a democratic manager and is satisfied being an influencer amongst their colleagues rather than a renowned leader in their specialty. They are respected by their peers not only for their clinical acumen, but for their diplomacy and willingness to listen. They enjoy the collegiality of working with their peers, both in their chosen specialty and even across others. They are the ultimate team player with an ability to be assertive and yet not authoritarian. They possess an almost intangible quality, we call it charisma, to effectively persuade their comrades to change their practice patterns. And as any consulting firm will tell you, doctors don't like to be told what to do, and they don't like change. So having a physician champion who can accomplish this for you is really an invaluable asset and instrumental in steering conversations toward cost and quality. When you've got the right person at the table, the tangible results become apparent in many aspects, including boosted staff morale, improved patient satisfaction scores, and cost savings. So I have an example of an effective physician champion in action. This example centers around the utilization of bladed trocars in the OR. Trocar spend was just north of $49,000. An initiative was brought to the peri-op team, which in this case was chaired by a transplant surgeon. And the initiative was presented wherein, as opposed to opening multiple bladed trocars, a single bladed trocar would be used, and various size port sleeves were used with that single blade to obtain abdominal access during the case. This very qualified physician took this proposition to his monthly surgery department meeting. He led a discussion there, and consensus was reached to move forward. Nurses were thereafter instructed to open only one bladed trocar and the appropriate sleeves. And this wound up translating into a savings of $24,000, or 49% of the total spend. And lest you think that that number is small, trivial, and maybe not worth all this effort, recall that in a 1% margin, only $5,000 of savings equates to $500,000 in new revenue to achieve the same benefit. So we've discussed that the medical staff are key participants in an era of system-wide change. We've enumerated ways to engage physicians in becoming part of this culture of change, and who are the best physicians to target. So the final step is to deploy a tool in the clinical setting that can be adopted by doctors and ultimately contribute to the dual goals of cost reduction and outcome optimization. And value analysis becomes the forum to do just this. As the healthcare delivery system moves from volume to value-based reimbursement, the ability for health systems to use outcomes data and comparative effectiveness to inform clinical decisions, from treatment protocol to device selection, is more important than ever. While 70% of U.S. hospitals report having a formal value analysis program, which is a critical process for informed, evidence-based decision-making, it turns out that really only 1 in 10 of those organizations has formally trained teams that are using true value analysis techniques. The remaining 90% are leaving non-salary supply cost reductions of an estimated 5 to 15% on the table each year. This is according to statistics from Healthcare Financial Management Association research. So organizations that are looking to take value analysis to the next level will need to adopt tactics from places that do it well. And again, at the cornerstone of this is physician engagement. As I stated earlier, physicians account for 80% of the decisions that drive cost, and therefore should have shared accountability and ownership in the procurement process. Too often, clinicians are faced with the outcomes of one-sided decisions by individuals who lack the total landscape view of the products and the outcomes they deliver. On the other hand, a physician-led value analysis program consisting of teams with representation from finance, nursing, supply chain, and clinical creates a platform for the supply chain professionals, institutional leadership, and the clinicians to develop strategic cost reduction initiatives in a manner that supports quality and safety measures, outstanding clinical outcomes, and decreased utilization across their facilities. A physician-led framework is a distinctive one. Over time, it has proven to be best practice in value analysis, aligning both hospital and physician objectives, creating a culture of compliance, facilitating collaboration, establishing clinical accountability for costs as well as outcomes, and enhancing procurement practices through new leverage with vendors as a result of physician engagement in purchasing. So it bears repeating that the people that head these value analysis teams should possess certain leadership qualities. You want to have physicians who are goal-oriented and have some sense of timeliness and urgency. They need to be recognized as clinically competent, but equally important as compelling communicators with a willingness to approach their peers and what are sometimes very uncomfortable conversations. They should be able to solicit feedback, articulate that back to a larger team, and contribute critical thinking in developing a new strategy that most effectively meets stated objectives. So I think of a particular interventional cardiologist who heads one of our CVIR value analysis teams at an academic facility. Completely new to value analysis, but selected by his peers, he so embraced the concepts and responsibility that he on his own presented to the team his own initiative idea around AngioPacks. As an interventionalist, he was acutely aware that major OR packs were being used when 90% of the cases were minors. He personally reviewed the pack contents to create a minor procedure pack, and with the value analysis team, negotiated pricing with the distributor. And for this institution, this is going to translate into a 14% savings or $9,000 savings on a $67,000 spend. For specialty-specific decisions, especially highly charged ones like orthopedic implants or CRM, Incorporate the relevant end users for a time-limited period to move the initiative through effectively and efficiently. Because they have the greatest vested interest, they can generate the most momentum in making product decisions and leverage their relationships with vendors to help in negotiating fair market pricing in exchange for preserving physician choice of supplies. These are the people who will also have the most direct and accurate knowledge of best practices, which can be instrumental in creating policies around product utilization. It can literally come down to the power of a single phone call. At one of our clients, there was a discussion around spinal implants, and this wound up being a conference call that involved 2 high-volume spine surgeons, 3 representatives from the implant company, the service line VP, the value analysis director, the OR nurse director, and a peri-op purchasing agent. The 2 physicians led the conversation and told the vendor reps that their help was needed on changing pricing on the highest volume spinal implants without any change in the actual products being used. They also stipulated that market share was not to be part of the conversation. The call lasted 30 minutes and in the end netted $240,000 in annual savings, all from a single phone call with vested physicians on the line. Most physicians believe that value analysis is rooted solely in financials. They will equate product change, particularly those levied on them without input, as being cheap. The process becomes more credible if there is the inclusion of objective, peer-reviewed studies. Physicians will adhere to a model that creates deliberate procurement practices using evidence-based outcomes. It is important for all members of the value analysis team to understand that lower cost does not have to mean buying the cheapest products. A value analysis team, a truly good one, evaluates products beyond price alone. They base their decisions on the product's overall safety and quality, as well as on utilization factors such as waste and appropriate use. Once again, having physicians on the value analysis team is a leg up in terms of having people who can not only interpret the clinical evidence, but share it with their colleagues in trying to win approval for a product or process change. By emphasizing product data and research, they are the best equipped to build consensus on product choices. At one well-run value analysis client, a radiology and a radiology tech, both of whom sat on the interventional value analysis team, noticed an increase in contrast media costs. They identified overusage of the more expensive VisiPake over Omnipaque, and this was beyond just utilization in high-risk patients. They brought this to the value analysis team for further investigation. An ad hoc team was created, which included the radiology nurse manager, a radiologist, and an interventional cardiologist. They determined that there was no policy in place, and VisiPake was being used indiscriminately in the radiology suite. They therefore created a policy based on a literature search into the appropriate use of contrast media, and additionally sought the input from 8 other physicians to ensure that they had their agreement with the policy. The new policy was presented to the radiology nursing staff and physicians at the departmental meeting, and thereafter implemented. So in this case, with absolutely no change in patient outcomes, VisiPake usage decreased dramatically and resulted in a $297,000 savings on a $981,000 spend. And this savings was purely on utilization and was initiated by and implemented by the relevant clinicians. It did not involve a change to a substandard product or not even a price change, but it focused on creating a more rational approach as to when to use which products were already on the hospital shelves. Successful value analysis means creating a structure. A good way to doom a well-intentioned value analysis program is to leave meeting schedules and plans for next steps unassigned. Meetings need to be at regularly scheduled times with published agendas that are provided ahead of time. Progress from previous meetings should be reported, and action items decided upon should be assigned to individuals and followed up on, even before the next meeting, in an effort to maintain momentum. Meetings that are chronically canceled or situations wherein assigned tasks are not attended to and carried over from meeting to meeting convey an overall lack of importance or organization and can spell death to initiatives. Build organization-wide support by communicating the success stories. This conveys the positive work, builds a consensus around the process, and becomes a motivator to others throughout the institution to embrace an agenda that centers on CQO. At the hospital that I work at, I regularly receive emails from the value analysis program leaders celebrating initiatives that have had significant impact. These emails detail the change in product or process that occurred. It reports the savings incurred and honors the key individuals who were involved in the change. Other examples of effective communication can include a scorecard in the OR lounge or in the physician lunchroom, postings in hospital newsletters, and funneling and reporting all team savings to a central steering group. So in conclusion, the realities of reform mean that inevitably there will be more meetings between hospital finance executives and physicians, and the impetus for cooperation is only going to increase. The hope is that these meetings become opportunities for collaboration around the issues of cost, quality, and outcomes. This transformation won't be an overnight one, highlighted by the fact that engaging physicians is a constant challenge. Bringing the right people to the table, communicating a culture of change, and creating a best-in-class value analysis program can tip the scales toward meaningful change that benefits everyone, including the patients. Elevating quality while decreasing costs is the only real sustainable strategy, and hospitals that partner with their physicians in achieving this will be the most competitive going forward. So that concludes my presentation. I'm happy to entertain any questions if there are any.
Thank you, Dr. Boehm, for a very informative and enjoyable presentation. We will now begin the Q&A portion of the program. As a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenter will attempt to answer as many questions as they can during the presentation and the time that we have for a Q&A, and we'll follow up on any questions she does not have the opportunity to address. Just to start off here, one of the first questions we had is, how do you respond to the physician who is worried about his or her results and potential malpractice in the face of having to switch to a product they're not familiar with?
That's a very legitimate concern. Certainly we don't want to be introducing any type of change that is going to, threaten malpractice to an individual or their institution. And there's a couple tactics to deal with that. Number one is around education. So anytime there is a type of change being introduced, it's important for whether it's a vendor, a manufacturer, or whoever is levying that change to really provide an educational component to the relevant end users, be it the physicians, therapists, et cetera. Number two is in terms of a strategy, is there are some people that are going to be early adopters and there are some people that prefer to be later adopters. And so I think in the spirit of compromise, if there are physicians that are a little hesitant and those that are maybe perhaps a little more on board with change, to allow almost like a staged adaptation, such that those who do become early adopters are then able to educate, demonstrate, or even mentor to their colleagues how the change has worked and gone well for them. And then the third strategy in terms of dealing with that is appeal to the fact that physicians are intelligent people. Typically the changes that are being levied don't involve a major change in practice or a major change in product. It's usually more at the level of some type of nuance that may feel a little different, look a little different, but at the end these are highly educated, intelligent people, and appeal to that aspect of their personality and encouraging them to consider looking at a product and adopting it.
Wonderful, very helpful. Another question that we had that come in was really great. Is you talked a little bit about physicians and specifically specialists like orthopedic specialists or interventionalists, but how can anesthesiologists share in this value proposition?
Actually, several of our clients have anesthesiologists as value analysis team leaders. Because in terms of cost reduction strategies, a lot of those types of items are derived from the OR. So anesthesiologists not only have knowledge of certain products both within the anesthesia space as well as what they hear from their colleagues on the other side of the table who are operating, but in addition they tend to have collegial and conversational relationships with the surgeons that they see in a variety of specialties. So they actually are wonderful team leaders because they haven't been pigeonholed into one certain specialty or another, but know a broad base of physicians and surgeons, and in addition can influence the the spend in their own anesthesia landscape. Things like anesthesia gases, product utilization is a big issue for anesthesiologists. So we've actually found in our experience that anesthesiologists can be invaluable members of value analysis teams.
Absolutely. Great. Thank you. We had another one of our attendees bring up a comment. They said, I feel the need for to embed a senior physician surgeon during a procedure being performed by a new attending because that leads to far better acceptance. How do you feel about that? Do you feel that embedding senior physicians can create more acceptance?
So, when we were talking about product change and, there being sometimes early adopters and later adopters, I think that having a colleague in the room who maybe have experience or expertise on a certain product that may be new to another physician is certainly a recommended strategy. And sometimes the notion of two heads being better than one, is certainly reasonable. In my own personal feeling is that oftentimes in terms of adaptability, there's sometimes a generational component, and oftentimes I find that it's a little bit of the younger or the newer physicians who are more willing to accept new products and to change than some of their colleagues who have just been doing it for a longer time and, for lack of a better term, are maybe a little more stuck in their ways. So, I think maybe it can be assessed on a personal level. You also have to take into account certain people's personalities, on an individual basis, but that's not an unreasonable strategy to invite colleagues to work together on a case or on a procedure in terms of learning how to best incorporate whether it's a new or different product into that particular case.
Definitely. It's very interesting. Great. Another question we have is, do you have physicians as part of your clinical value analysis teams, or do you separate physicians from the value analysis teams?
No, that's my point, is that the value analysis teams that we have at our hospitals are all physician-led. So physicians not only lead the teams, but are also members of the teams as well. Now, those teams also include nurses, infection control, individuals from finance, individuals from supply chain. But what we found is that, because the physician engagement is so important, having the physicians lead and drive the strategy has been invaluable in actually getting real and tangible results.
Great. Thank you so much for expanding on that. Another question we had, everyone's kind of looking for a silver bullet, and I won't be that, but tips are always really, really helpful. And one of our audience members, is wondering what are the top 3 resources you rely on when dealing with this process?
In terms of, I guess I don't know in terms of obtaining evidence or in terms of what tactics we employ. I think that if I'm interpreting the question correctly, bringing evidence to the table. So, whether it's around a product or process, physicians like data, and it's ultimately physicians that we're asking to change. And so the more that you can bring white paper evidence, scientific evidence to the table, that resonates very well. I think we talked, I mentioned bringing change leaders in early on in the process. So not making unilateral decisions and then levying them on physicians, but bringing them into the decision-making process so that they feel like, number one, their voice has been heard and that they have a vested interest in the outcomes, which is not only based on cost reduction, but patient quality and patient outcomes as well. So those are 2 very useful strategies. And I think just there has to be a certain amount of patience as well. Change doesn't come easy to anyone, and it certainly doesn't come easy to physicians, and as I mentioned, particularly people that have been doing it well for a long time. And so, we have to accept the fact that we're not going to win every battle, and that, sometimes things may need to take a little break and be revisited, but that ultimately persistence, communication, the use of data, those are the types of things that can eventually swing the pendulum to the other side.
Wonderful. I definitely think that answered our attendees' questions, so much appreciated. Another great question we have is, in an effort to transition from a products committee platform to a true value analysis program or framework, how would you recommend overcoming a "this is how we've always done it" mentality from your administration or leadership?
Yeah. So, it really has to be about the fact that this may be how you've always done it, but that some of those compelling statistics that I related in the beginning, apparently we're not doing it well. People are operating in negative profit margins, hospitals are having to close, full-time employees are having to be let go because the budget just doesn't allow to have them. And so, while this may be how we've always done things, it's not working. And so ultimately, if we're going to be sustainable, we have to change. And part of that change strategy can be, as we enumerated here, creating a really functional value analysis team, not just a product selection committee, not a standardization committee, but one that has physicians leading it, one that looks at data and evidence, and it generates discussion and not unilateral decisions around product and process change.
Absolutely. Great question. So switching from administrators to dealing with physicians again, one of our audience members wants to know, what is the best response when a physician asks if they do help? Other than better patient outcomes, they want to know what financial rewards there will be when savings are achieved.
Right. What's in it for them?
Right.
And that's tricky. You have to kind of like to express that the greater good is for the hospital, and that it's not necessarily going to the physician bottom line. It actually becomes a little bit of a legal issue in terms of the fact that you can't actually pay physicians to use or not use a certain product, because that starts to get kind of dangerously close to what we call kickbacks. But we emphasize that there are non-financial rewards, things like meeting certain goals or certain objectives means that your contract is renewed if that's a hospital-employed physician. It may mean your admitting privileges are extended for another year. You can also do certain other privileges, such as those physicians that have been active participants maybe have first choice in terms of add-on time or block time in the operating room. Emphasize the fact that without the institution remaining viable, those physicians might not have a job. And so while it doesn't necessarily go to their own personal bottom line in their wallet, maintaining a hospital means that they have a place to work, as well as all the people that hospital employs.
Excellent point. Yeah, emphasizing the bigger picture. Great.
Exactly.
Great. Well, we've talked a little bit about dealing with physicians, administration, and one of our audience members wants to know, and I'm sure they're speaking for several others, how to deal with vendors. They want to know how open the value analysis team is to ideas brought forward by a vendor, and how would a vendor successfully access the team leader to start a discussion around value-added outcomes.
So what has been the traditional model is that vendors like to talk to physicians, because it's very easy to sell physicians on new technology that has certain bells or whistles associated with it. But really going forward, the strategy has to be to bring vendors into talk with simultaneously with physicians and with supply chain professionals, because then both areas or both needs, I guess, are being met, meaning the physician who's interested in what technology can do, and supply chain who's going to be a little more interested in what this technology can cost. So by having all those players together in one room, it actually prevents miscommunication and a more fruitful discussion right from the onset, versus getting someone on board with a product and then having to say, well, it's this cost and there's no negotiation. So truly being a willingness on the part of the vendors or the manufacturers to have open discussion with all the involved players, meaning involved in terms of clinical as well as pricing, becomes a good strategy.
Wonderful. Great. The next question we have here, let me see. Sorry, we have so many great questions coming in. Okay, the next
people are asking fantastic questions.
I know, definitely. The next question we have is, what are the ways physicians can be monetarily rewarded for their participation in the Value Program? I know you touched on this a little bit earlier. There's some legal issues around it, but there's still some question about that.
There are, yeah. So the other thing is that sometimes the rewards can be translated in ways that aren't necessarily hard dollars and cents, but certain perks or privileges or even physical gifts that come from the hospital, such as, for example, maybe all the physicians that are able to rally behind a certain initiative receive new headlights or get new OR shoes. They may have, the hospital may be willing to provide some funding for something like a physician extender or a nurse practitioner for a particular department if they're able to meet the metrics that are established for them. And it's very hard, I'm not saying it's impossible, but it's very hard to give actual dollars and cents back to a physician. And if your institution is thinking about that, I would definitely get the advice of legal counsel to craft it in a way that is certainly law-abiding. But in terms of perhaps still, quote-unquote, financial rewards, but not necessarily hard dollars and cents, you can start to look at those other types of things that fall into the space that are deemed reasonable.
Great, wonderful. Well, we have time for just another few questions, getting towards the end here, so I'm just going to ask a last few. One of our audience members wants to know, how do you convey to surgeons to move forward not having a manufacturer representative in the operating room during surgery, that this also adds cost of product? Adds to the cost of product, I'm sorry.
I'm sorry, that having the vendor in the operating room adds to the cost?
How can you convey, I'm sorry, how do you convey to surgeons that not having manufacturer in the operating room during surgery adds cost to the product?
So actually what's expensive is having vendors in the operating room. That becomes an expensive paradigm. And you have to understand that physicians, particularly some that are in rural areas or maybe the only physician in their specialty, having a vendor that they can collaborate with is sometimes their only means of education about new products, new technologies, or new ways of doing things. But again, the important thing is that to not have those conversations in isolation, but to bring in other people that are more willing to talk about price. Physicians don't like to talk about price. So to bring in the experts that do, which is your supply chain professionals, and to have those types of conversations in that type of environment. You know, that certainly has been what we found in our value analysis team. When you bring all those players together, they're willing to negotiate. Much more than if they're willing to just, you know, talk one-on-one with a physician and then come separately to a supply chain professional and say, well, I've got a physician on board and this is what you're going to pay.
Got it. Got it. Yeah, I think I might have misread our question, so I think you understood it better than I.
Okay.
Absolutely. Great. Well, just one last question here. One of our audience members wants to know where to find the best practices for VAT.
Mm-hmm. Yeah. So, you know, again, this is where having the physicians as part of the team can be invaluable because they have access to the clinical journals and the white papers from their specialty-specific journals. So, you know, so if you have an orthopedic surgeon either on your team or if it's around an initiative, you know, specific initiative on orthopedic joints, have that ad hoc, time-limited orthopedic group who are familiar with the white papers that are out there, who have been to recent meetings in their specialty and know what the latest technology is and what their peers are doing. They become the greatest resource to know what is standard of practice and best practice, and then make the decisions based on that.
Wonderful. Well, I see we have quite a few more questions here about value-based proposition metrics and dealing with third-party payers, but unfortunately we are out of time. Just as a reminder to our attendees, you will receive a follow-up email shortly after the completion of the program. So if you do have more questions, by all means submit them, and you know, our presenter will follow up with you. So I want to thank Dr. Boehm again for her excellent presentation, for all of you for participating today. We look forward to having you join us for future webinars. This concludes